Okay, Assalamualaikum. Okay, assalamualaikum warahmatullahi wabarakatuh. First of all, saya kat rumah, pasal ada orang tengah baiki something, semua macam bising sikit lah. So ada satu je kan nak present kan? So this should take less than 30 minutes. Kejap, boleh tak bagi saya 2 minit, saya nak save something kejap. Mana? Okay. Okay, so boleh present lah.
Hello.
Hello.
Okay, okay, Doktor. Saya Arisha. Okay, so I will present this case. Akilah 9-year-old Malaysia with underlying uncontrolled diabetes mellitus type 1 as evidence of HbA1c 9.3 presented to emergency department of SASMED due to lethargy for 1 day. So the history was taken from her mother. The child was apparently well until 1 day prior to admission, which she experienced lethargy. It was sudden in onset as it occurred while she was eating in the evening, and it was associated with sleepiness and pallor. Hence the child lie on the bed throughout the day, and and then beside that, the child also complained of having cramping abdominal pain. It was centrally located, intermittent but tolerable. The pain did not radiate to other side and no aggravating factor. Otherwise, there was no diarrhea, nausea and vomit, fever, bloody stool, and history of eating outside. During illness, the dextrose reading was 25 millimole per liter, which was increased compared to pre-meal, which was 30 millimole per liter. Hence, her mother injected insulin, Novorapid 8 unit and determine 9 unit to reduce the blood glucose. However, after 3 hours of insulin injection, the dextrose reading become more worsened as it increased to 31 millimole per liter. Due to worsening of the blood glucose level and persistent lethargy, the patient was brought to ED SASMED immediately. Hence, emergency department, the dextrose recorded was 21 millimole per liter. The blood investigation was taken and she was infused with intravenous fluid. She was admitted to pediatric ward for correction of her blood glucose level. Otherwise, there was no sweating, shortness of breath, consciousness, hyperglycemic symptoms such as increased frequency urination, excessive thirst or hunger, excessive urination at night, and weight loss. No symptom of infection such as fever, cough, headache, dysuria, false smelling, and ear pain, and no history of the sick contact. No palpitation, chest pain, and no symptom of the shock such as dizziness, loss of consciousness, oliguria, and cold skin. And this is her second hospital admission with the same presentation that had occurred 6 months ago. Cool. Okay. So upon further questioning, she had been diagnosed with diabetes mellitus type 1 since 8 months ago. At that time, she had lethargy for 3 days associated with polyuria, nocturia, polydipsia, and loss of weight. As her mother noticed, the clothes of her daughter become more loose. And the child weight during the diagnosis was 24 kilogram. Uh, then on day 4 of illness, the child condition become more worsened as she had loss of consciousness. And then worried about the child's condition, the mother brought her child to ED of HUSM for further treatment. During that time, the dextrose reading was 22 millimole per liter, and she was warded for 1 week and treated with free infusion insulin. Mm. Since then, since she had been diagnosed with diabetes mellitus type 1, she was treated with Prebet, Insulatard, and Atrapid on pre-breakfast, post-lunch, and pre-dinner insulin injection during normal time. After 3 months, the insulin regime was changed to Novorapid, Determi, and Atrapid. The Atrapid was taken pre-breakfast during school holiday. Novorapid taken on before or after each meal during snacking and when has uh, high blood glucose level. And Determi was taken during pre-breakfast, which is 7 unit, pre-dinner 9 unit. And then the self-monitoring blood glucose was taken 4 times per day, which the reading were high. For example, for pre-lunch is 12 to 40, pre-dinner 50 to 20, and before sleeping is 10 to 15. And the blood glucose level was normal on pre-breakfast only, which range between 4 to 9. And then there is there is protein need of insulin injection, as there is repeated usage of needles due to financial problem. Otherwise, the child is compliant to medication with adequate dosage insulin injection based on carbohydrate requirement, and also the usage of new site for each injection of insulin, the good insulin storage as the child put the insulin in chiller. And also for diet, she heavily miss 3 times and have snacky times. For example, during the breakfast, the child take formula milk, nasi lemak, and also for the lunch, she take rice with chicken, chicken, fish, and also during snacking, she consume biscuit, a cup of uh juice, and also during dinner she eats a rice with chicken and fruits. She is atypical since she does not eat vegetable. And also regarding his diabetes mellitus type 1, she also had follow up HUSM 3 monthly, and suspect for two monthly, and she was compliant to follow up. And also regarding the complication of his illness, there was several episode of hypoglycemia, especially during the child do vigorous activity with dextrose reading between 1.9 to 2.8, and it was resolved by eating sweets. Otherwise, there was no blurry vision, frothy urine, limb weakness, numbness, ethically sensation, intermittent claudication, and recurrent skin infection. Okay. So that's for Hoppy. And then for the past medical history, the child was diagnosed with latest mellitus type 1 since 8 months ago, and 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 previously there is history of admission due to lethargy, and also one history of admission for changing her insulin. Otherwise, there was no history admission to ICU and no surgical procedure had been done. And the child also has allergy to it as
Kejap, guys, sorry.
okay.
Okay, I'll continue. Hello? Chinese. Hello.
Okay, sorry, Doctor, sorry. Okay, so okay, so the child also has allergy to egg, as she will develop rash at perioral. Otherwise there was no drug allergy. And then for drug history, she is on novorapid, vitamin, and atropine insulin injection and was compliance to medication. And then for the for birth history, uh for antenatal, the mother has history of the gestational diabetes mellitus on diet control. And she was delivered via spontaneous vaginal delivery at 40 weeks with birth weight 2.9 kilogram. And then for the postnatal, there was no neonatal hypoglycemia. Um, and then for immunization history, it was complete up to her age. However, the child has developed rash during MMR injection because she has allergy to it. However, it was still limited and was prescribed with antihistamine. Mm. And then for developmental history, she is a slow learner. As evidence, cannot read reading. She cannot reading. Cannot reading. Otherwise, she can speak and write. Also, okay. And also she is able to socialize well, as she can play with friends at the school, and she can eat, dress, and ambulate independently. Okay, for family history, there is uh, her grandparents have diabetes mellitus that was diagnosed when elderly. Otherwise, there was no family history of the similar disease, autoimmune disease, and malignancy. And for social history, she is out of four siblings, which her sister is 60 year old, brother 40 year old, and younger brother 2 year old. All of them are healthy. However, the father has passed away 2 years ago due to meningitis at 32 year old. And her mother is 6 year old and self-employed, and she is healthy. The house monthly income is 500, and her family receive financial help from Jabatan Kebajikan Malaysia about 600 ringgit per month. And then she live with her families at Kapun Sungai Luit, Maran, in quarters equipped with basic amenities. And then for the treatment of her diabetes mellitus, uh, she spent about 500 monthly. And also the mother went to each appointment by driving car. So for physical examination on general, she is thin, and she was sleeping on the bed in the supine position and supported with one pillow. And then, however, there was no no Kussmaul breathing and acetone breath, and she is not in pain but look fatigued. and she is pink with no jaundice, cyanosis, and pallor, and have moderate dehydration. As evidence, she is lethargic and have dry mucous membrane. However, the capillary time is less than 2 seconds and no more skin trigger. Uh, there is cannula attached to her right dorsum with normal saline 0.9% infusion and right antebrachial fossa with slow active insulin infusion. And also there is straw colored urine about 100 milliliter in continuous bladder drainage. For the vital sign, the vital sign was normal as she is a febrile. The pulse rate is normal with regular rhythm and good volume. The blood pressure is normotensive and respiratory rate is normal. And then for anthropometric measurement, the child has height is above 95 centi, which about 145 centimeter, but the weight is 35.5 kilogram. Hence, the BMI is considered as normal, underweight 16.9. Okay, and then for the cardiovascular system, um, the for system, the JVP was not raised, and then on palpation, the epidemic was in fifth intercostal space, and then the S1 S2 was heard with no murmur and added sound. And then for respiratory examination, the uh, the chest was moved symmetrically, and and then uh, okay, and then on percussion, all zones are resonant. And auscultation, there is vesicular breathing sound with no crepitation and rhonchi. And for abdominal examination, the abdomen with move symmetry with respiration. For no bruising, scar, lipodystrophy, and lipoatrophy at insulin injection site. Okay, and then on palpation, the abdomen was soft and non-tender, and there is no organomegaly. Okay. And then on auscultation, the normal bowel sound was heard. And for central nervous system, the muscle bulk, tone, and power were normal, reflex were normal, and sensory was normal. Cranial was intact. So for summary, Akilah 9-year-old Malaysia with underlying uncontrolled diabetes mellitus type 1 presented to ED suspect due to lethargic for 1 day. It was associated with abdominal pain, pallor, and sleepiness. And then for further history, there was poor technique of insulin injection as repeated usage of needle. Otherwise, there was no history of there was no symptom of hyperglycemia, infection, and shock. And on physical examination, she is fatigue with moderate dehydration, no Kussmaul breathing, and aceto breath. And also there is no complication at site of the insulin injection. Okay, so my provincial diagnosis is diabetes ketoacidosis secondary to uncontrolled diabetes mellitus type 1 due to poor technique insulin injection. Okay. My other differential diagnosis is diabetes mellitus. Okay, my other differential diagnosis is diabetes ketoacidosis. Secondary to acute appendicitis because the patient has abdominal pain. However, for the points against, there is no fever, vomiting, and also the pain is tolerable. And then my other differential diagnosis is hyperglycemic hyperosmolar state because the capillary blood glucose was high, which is 31. And also the patient also has underlying of the diabetes mellitus. However, for the points against, there is no history of hyperglycemia symptom, and also not the patient is not diabetes mellitus type 2 because hyperglycemic hyperosmolar state commonly occur in diabetes mellitus type 2. 2. Okay. Okay, so and also the differential diagnosis is diabetes ketoacidosis, secondary to acute coronary syndrome, syndrome, because for the points for the patient has lethargy, and also the patient has abdominal pain. How pain, and also the patient also has uncontrolled diabetes mellitus that can be the risk factor to develop acute coronary syndrome. However, for the points against, the patient does not have sweating, the pain radiate to the jaw and to the left side of the arm. The arm. Okay. And also on physical examination, there is no finding on cardiovascular examination. Okay. So that's all for differential diagnosis. And then, okay, next I want to proceed to the investigation to confirm my
Anis,
diagnosis.
Anis.
Okay.
Saya rasa dalam investigation lain kali lah. Okay,
Okay.
the focus today kita just focus on the history lah. Tapi since you dah present physical examination, then I just okay je lah. So any comment, guys? What do you think about the history?
For me, I think I would like to know how is actually patient able to get hyperglycemic, how actually patient able to have diabetic ketoacidosis, because from the history I couldn't recognize it.
Okay, true, agree. Okay, so maksud dia you want, I mean this time around dia during this acute admission, why patient got DKA kan?
Yes.
Okay, I agree with you. It's quite difficult, but from the history, the acute part of the history is not very clear, and doesn't give us clue why patient got DKA. Kan? Anyone else? Okay, in general, the history okay lah, quite detailed. I mean there's a flow lah, good flow. Initially you give background and then you start to talk about the acute presentation, and then you mentioned about the past medical history. You include the diagnosis at the section of past medical history. Which I think that's good. I mean, we can clearly see the layout and it's quite systematic lah. And then what I like is that you give summary and then you explain. For example, like untuk development, you say she is a slow learner. Her speech, slow learner. This is evidenced by she still cannot read kan? Dia cakap lebih macam tu. At standard 3, she still cannot read. Okay. And then there are part one where you actually give clues kan. You give like she cannot ni, and then so you got conclusion. That is also a way lah. So you can start with conclusion and then followed by elaboration, or the other way around. So for example, macam development tadi, you can also say developmentally, despite 9 years old, she can only talk like incomplete sentence or simple sentence. she can walk but cannot run macam tu lah. So which correlates with the developmental age of berapa-berapa. Okay, macam tu kan. Okay, otherwise the history, I would prefer, semalam you ada waktu I cakap macam nak present history. Semalam you tak ada Ke you ada?
Yang kat klinik ke?
Kat klinik.
Ada.
You salah seorang
Semua grup kita orang.
Kat klinik semalam you you yang tengok patient yang hydrocephalus Ke
Tak,
you one
ada.
of the 4 yang duduk dengan I tu?
104.
Okay. So that's good. I think overall okay lah dia punya flow. Cuma macam case macam complicated macam ni kan. You kena, what important is you need to be clearly define your timeline. Macam tu. So you need to use a lot of word yang ada temporal punya konsep lah. Temporal means time punya konsep. So contoh for example macam she's currently admitted to the ward because of with the complaint of lethargic. Okay, 1 day history of lethargic. And then you present. And then pre-morbidly, prior to the illness, she is well. Ataupun you start dengan she was previous in the past she was well until about 8 months ago, where she was diagnosed with diabetes. Okay, the diagnosis the diagnosis made in HUSM when she was presented with apa-apa. So cakap past, present, acute now, present, and then kalau patient chronic macam ni, the pre-morbid punya control, pre-morbid punya background. Okay, so dia ada 3 timeline lah. Satu, what to diagnosis, and then progression from diagnosis until now, and then acutely. Macam mana dia sekarang. Otherwise okay lah, yang lain I rasa complete lah. And then the physical examination, okay, is very good. Okay, because you start with general overview, said the child looks well, normal build. So you bagi description about the child lah kan. So I tak nampak the child. So you give description. So my idea is, okay, this is child, normal build child. Cuma sebab thin kan. I tak agree with you. This child is not thin. Okay, she's not thin lah. She's quite a big build for 8-year-old. For 8-9-year-olds. She's quite a big. She's got a big build. Cuma you should mention, you give her description. So kalau contoh you kata, Akila looks sick, then I can think of, maybe very poor control lah, very poor control DM. So you give us idea lah. And then you mention, you put analysis in your presentation. For example, you mention there's no evidence of small breathing. Rather than you just say tachypneic with shallow breathing, alternate shallow and tachypnea, you give conclusion, which is very good. So no small breathing. Cuma moderate dehydration tu I'm not sure whether this is true lah. Tak rasa dia dehydrated at all. Tapi tak apalah. Sebenarnya moderate dehydration pun bagus. But you mentioned she shows moderate dehydration, and then you elaborate kan. You kata because she looks lethargic, and then dry lips. So that's good. So you boleh bagi summary and then you bagi elaboration. Ataupun you bagi elaboration then summary. Cuma kalau DM kan, it's good to mention about acanthosis nigricans lah. You can mention about acanthosis nigricans. And then ada comorbids. What are the comorbids yang ada associated disease associated with type 1 DM? Apa dia?
Thyroid, Graves disease.
Graves kan? Autoimmune lah, especially autoimmune thyroiditis. So you can mention there's no evidence, there's no clinical signs of autoimmune thyroiditis atau Graves. You kena sebut. But these are something yang you kena look for. And then you boleh tak cakap there's no skin problem. Saya nak tahu psoriasis. Takut dia ada psoriasis kan. Because they are actually autoimmune connected lah. Tu cukup. This is sebab I dah experience mana. So your presentation is very good lah. Okay, anyone got anything to add?
Doktor, kalau untuk for the autoimmune disease that commonly settled in Taiwan is grave disease, cirrhosis, and then apa lagi?
Macam ni? Psoriasis?
Cirrhosis.
Ni. Dia the most common is actually celiac. Okay, the most common association with is celiac. Celiac because it's autoimmune lah. Tapi because epidemiologically, type 1 DM is most common dekat Scandinavian country. Okay, dekat Norway no. Kat Norway, Sweden, these are the most prevalence lah type 1 DM. That's why dia buat screening. Dia buat screening untuk HLA-B27 untuk semua baby. Saat dia detect very early type 1 DM. So because celiac is very prevalent there, so ada association lah dengan celiac. Tapi kalau kat Malaysia is thyroid lah. Grief. Okay, thyroiditis, autoimmune thyroiditis, vitiligo, psoriasis tak nak, vitiligo dengan autoimmune thyroiditis. Tapi kalau patient contoh macam very strong history of autoimmune kan, you kena screen for celiac kalau kat Malaysia. And you'll be surprised they got celiac. Sebab dia memang closely related lah. Cuma kat Malaysia kita tak celiac.
Doktor terkeluar.
Assalamualaikum guys. Dengar tak? Sorry lah, ada orang call lah. Saya guna phone, internet phone, so dia stop. Rasa tu je lah tu. Tu je lah dulu kot. Ada anything else? Okay. So saya boleh bagi makan 85 boleh kot. Anything you just WhatsApp me lah kalau anything you want to ask. Okay.
Doktor, do we need to know about the management of DKA in ED?
Definitely. You 5 kan, you kena tahu lah. Tapi yang tu later kot sebab I ada something else.
Okay.
Later lah nanti kita jumpa atau bila kita boleh discuss lah buat management of DKA.
Okay, doktor.
Okay. Kau tak boleh baca lah dulu. Nanti apa-apa you tanya. Okay lah.
Okay.
So,
Thank you.
Thank you, doktor.
Thank you, doktor.